Approach to abdominal pain in children. In this video, we will be discussing the approach to abdominal pain. We will first consider a list of differential diagnoses, and then discuss the approach to acute and chronic abdominal pain, going through each step of history, physical examination, and investigations. These are the causes of abdominal pain. Here is an overview of the differentials for causes of abdominal pain. They can be divided into acute and chronic causes, and under acute causes, most importantly, you must rule out surgical causes because many of these are time critical. In all age groups, one must also rule out appendicitis in any child with severe abdominal pain. If missed, the appendix may perforate, leading to greater morbidity and even mortality. Also, hernia orifices should always be inspected for presence of hernia. In adolescent females and older, it is important to consider ectopic pregnancy. Other gynecological problems like ovarian cysts with complications should also be considered. These can be present with nonspecific lower abdominal pain. For boys, testicular torsion can also present with abdominal pain in the lower quadrants. Hence, the testis must always be palpated looking for tenderness, swelling, or abnormal lie of the testis.
After ruling out surgical causes, one can then move on to the non-surgical causes. Gastroenteritis is common and is usually associated with vomiting and diarrhea. However, do not miss a urinary tract infection. This may present as suprapubic tenderness in cystitis or even as loin pain in pyelonephritis. Metabolic causes like diabetic ketoacidosis may also present with non-specific abdominal pain, and the child usually has significant dehydration. Do not forget that pathologies in the lower part of the chest, like basal pneumonia or even myocarditis, can present as upper abdominal pain. Looking at the chronic causes of abdominal pain, we divide these into organic versus functional. We first rule out organic causes like inflammatory bowel disease and malignancies. Constipation is a very common cause of chronic recurrent abdominal pain and should always be thought about. Following that, the functional causes of abdominal pain are possible diagnoses. These include irritable bowel syndrome, functional dyspepsia, abdominal migraine, and aerophagia. When taking a history of abdominal pain, ask about the location of the pain. Right iliac fossa pain is a red flag for appendicitis, but can also occur in interception. Suprapubic pain localizes to the bladder and pelvis, while pain over the groin points towards an inguinal hernia or testicular torsion. Fever is present in infection and inflammation. Vomiting is an important associated symptom. Do not forget to ask about the nature of the vomitus, because bilious vomiting points towards an obstruction distal to the ampulla of vata. Ask about diarrhea. If bloody diarrhea is present, the differentials include bacterial gastroenteritis, anal fissure, or is a late sign in interception. Abdominal distension points to a possible distal obstruction and is common if antimotility agents were used for acute gastroenteritis. Specific symptoms point to specific diagnoses. For example, in Henoch-Schönlein purpura, non-blanchable purpuric rash is commonly seen over the shins, while periorbital and peripheral edema is seen in nephrotic syndrome, where there may be ascites or even the dangerous complication of spontaneous bacterial peritonitis, which may account for abdominal pain. DKA classically presents with prior polyuria and polydipsia, while pneumonia is associated with cough, shortness of breath, or even chest pain.
Acute abdominal pain, physical examination. Heart rate, respiratory rate, and blood pressure norms are age-related. In dehydration, tachycardia precedes a fall in blood pressure.
On general inspection, look for signs of dehydration. Look at the mucosal surfaces, presence or lack of tears, decreased perfusion to the peripheries, and even sunken eyes or poor skin turgor. On abdominal examination, inspect for distension and palpate carefully to localize the area of most marked tenderness. Remember that visceral pain often refers to the periumbilical region initially, before localizing to the specific quadrant where the pathology is. Palpate carefully for masses. Rebound tenderness and guarding are red flags that point to a surgical cause. Complete the examination by auscultating for bowel sounds. Look at the perineum. Examine the testes carefully for torsion, where there will be extreme tenderness, abnormal transverse lie, as well as the loss of cremasteric reflex. Testicular tenderness can also be present in epididymitis, and the elevation of the affected scrotum then relieves the pain. This is Pren sign. Also look out for anal fissures.
Here, we discuss signs specific to appendicitis. Rebound tenderness is typically localized to the McBurney point. Psoas sign in the presence of right iliac fossa pain when there is flexion of the right hip against resistance, while the hop test is pain in the right iliac fossa while hopping on one leg.
Moving on to investigations, a raised total white blood count points towards appendicitis or bacterial cause of gastroenteritis. A urine microscopic analysis is useful to look for pyuria, which would be present in urinary tract infections. When indicated, a blood gas can be done to look for metabolic acidosis. If the child appears unwell or is clinically dehydrated, electrolytes should be screened for abnormalities. An abdominal radiograph is not always indicated in abdominal pain. These radiographs display some classical signs. The first one on the left shows small bowel obstruction. Specifically, when done, small bowel intestinal obstruction would give the appearance of a stack of coins due to the plicae secularis crossing the entire width of the dilated bowel, while in more distal obstruction, the dilated bowel loops may appear more like sausages, identified by the presence of horstrations. The next abdominal X-ray shows the presence of intersusception with paucity of gas in the right lower and right upper quadrants. Ultrasound abdomen is useful for picking up appendicitis as well as intersusception.
This is an ultrasound showing appendicitis with an inflamed, thickened appendix with surrounding free fluid. This is an ultrasound showing the classic target sign of intersusception. Having discussed causes of acute abdominal pain, we will now explore causes of chronic abdominal pain, which is defined as at least 3 pain episodes over at least 3 months interfering with function.
Look out for the red flags on history. Ask about the severity of the abdominal pain, especially those with nocturnal awakening. Ask about changes in bowel habits, especially chronic diarrhea or persistent vomiting. Ask about associated symptoms that may be found in malignancy and autoimmune disease. These include recurrent oral ulcers, joint involvement, rash, loss of weight and appetite, and recurrent fever. Examine for any localized tenderness in the right upper or right lower quadrants, any fullness or mass effect. Always palpate for the presence of any organomegaly, and look at the perianal region for stigmata that would suggest inflammatory bowel disease. Investigations depend on the findings from history and physical examination. Full blood count is useful when looking for anemia, specifically whether anemia is normocytic, normochromic, as in chronic illness, or microcytic, hypochromic in iron deficiency from blood loss. Also, the total white and differential counts help in making a diagnosis on the presence of bacterial infection. CRP is a useful inflammatory marker for acute infection, while ESR for chronic inflammation. The liver function test would show the level of albumin, giving the nutritional state of the child, and also reveal the presence of any transaminitis. Stool tests should be tailored specifically to the clinical suspicions for each patient. These include stool occult blood, stool bacterial cultures, stool for ova, cysts, and parasites, as well as Clostridium difficile toxin assay. Autoimmune markers may be performed if inflammatory bowel disease is suspected. In conclusion, the key to diagnosis is a good history and physical examination. In acute abdominal pain, always remember to think outside the box. If there is significant dehydration out of proportion to the presenting symptoms, always ask about preceding symptoms of polyuria, polydipsia, loss of weight, as this patient may be presenting with diabetic ketoacidosis. With respiratory symptoms and minimal tenderness on abdominal palpation, consider referred pain from the chest, as in the case of basal pneumonia. Do not forget about urinary tract infections, which are commonly seen, and remember to rule out gynecological causes in all adolescent females. In chronic abdominal pain, this is a common complaint in pediatrics. Look out for the red flags as mentioned above. Remember to take a thorough family and social history, as this may reveal triggers for causes of functional abdominal pain.
Quiz time. Question 1. Which of the following cannot be elicited in appendicitis? Is it Prenz sign, Sower sign, Rolfsing sign, or Dunphy sign? The answer is Prenz sign. Question 2. Which of the following is not an organic cause of chronic abdominal pain? Inflammatory bowel disease, constipation, irritable bowel syndrome, or malignancies? The answer is irritable bowel syndrome.